I'm Michael Krasny, and I am pleased to welcome you to another weekly episode of the Gray Matter with Michael Krasny podcast. We invite those of you listening to join our deep dive interview and interactive global podcast marked by technical excellence and the covering of a wide range of intellectually stimulating and highly engaging topics with leading experts, authors, artists, scientists, and opinion shapers. So do sign up if you haven't yet and become a member in good standing by going to graymatter.show, and that's gray with an E. In this episode, we welcome Dr. Nolan Williams, a neurologist and psychiatrist and Stanford associate professor who directs the Stanford Brain Stimulation Lab and Stanford Interventional Psychiatry Clinical Research. He's a leading national researcher and award-winning scientist, and his work resulted in FDA clearance for the world's first non-invasive, rapid-acting non-modulation approach for treatment of resistant depression. We'll talk about that more and maybe put some lucidity on what that all means and what his research means. But he has been looking for many years into and investigating symptoms of mental health and struggles with, shall we say, the afflictions that can be tempered and in many ways actually remedied, or certainly not necessarily vanquished, but ameliorated with long-time substance abuse. And we'll talk about also some of those substances and what they mean and what some are looking at as a new renaissance with respect particularly to psychedelics. Many of his works have been published, his papers, in several peer-reviewed high-impact journals, and he's a recipient, among many other awards, of the National Institute of Mental Health Behavioral Research Award for Innovative New Scientists. He holds a medical degree from the University of South Carolina Medical School. And let me add the fact that 3 other episodes on Gray Matter with Michael Krasny feature related interviews, including number 36 with Dr. Williams' Stanford colleague, Dr. David Spiegel, and number 38 with psychiatrist and expert on psychosis, Dr. Ira Steinman, as well as our 57th episode with Larry Smith and Melanie Abrams, authors of The Joy of Cannabis. And now I welcome Dr. Professor Nolan Williams. Good to have you with us.
Hey, Michael. Thanks for having me. Excited to have this conversation.
Well, so am I, and I'm excited to find out from you what's most exciting before we get into specifics of your research and other research, because, like I say, there's been a kind of sea change in terms of the sort of research that's being done. The government seems a little more open. The hurdles that were there seem to be coming down. That's allowed you to do a lot of the research that you're doing. I want to find out where we stand, but first of all, what's on the horizon? What looks most promising and exciting to you?
Yeah, I think the theme of the lab that's pretty consistent throughout all of what we're trying to do is this idea of what people call rapid acting treatments, right? So being able to treat people with neuropsychiatric illness in a much shortened time frame, so that the expectation is instead of getting well in months, for some people years, they're able to get well in days, and in some circumstances, hours, right? And that's...
Excuse me, when you say get well, you don't mean the normal of 0 here, do you?
Yeah. I mean, we've had patients across several different treatment modalities where their symptoms are eliminated and they're within the normal healthy control range within, just a few days, right? And that to me is kind of right aligning the level of disability and acuity that folks experience from suffering from neuropsychiatric illness with the rest of medicine, right? Like, we don't accept treatments that take months and years, for some people decades, to treat heart attacks or other acute illnesses, right? We think we need to get in there and deal with it within short periods of time, and those are considered medical emergencies. And I'd say we're in a similar spot with something like a suicidal depression, where, if you don't have a really rapid acting treatment to treat that once the person's come into the hospital, then their risk for having a suicide attempt or having a completed suicide after they get out of the hospital actually triples. And so this idea that we really need to be of that same mindset of treating people as rapidly and as completely as we can in short periods of time for these illnesses. And then from that, like, back engineering how to do that, and you mentioned psychedelics, and that's certainly one area where you've got a rapid acting treatment, and then also the neuromodulation work that we've done. So that's the kind of thematic kind of overlay of everything that we do, is really that mission of being able to get people well quickly. And then, we're pretty open to however we can do it, as long as it's acceptable to the patient, ultimately to the FDA, that the risk benefit is something that I would accept for myself, for my family members, then that's really the kind of the metrics that we use, and that's the way we've approached the problem.
You mentioned neuromodulation. That regulates signals that are sent to the brain, as opposed to non-modulation, which is specifically what I mentioned in conjunction with your research. The SAINT program comes to mind, which was done it's accelerated TMS, which was done at Stanford, and that's very fast now. I mean, in terms of the kind of results that you're talking about.
Yeah, absolutely. So we observed in our first trial that folks can get to remission, which is absences of symptoms at a level that they meet diagnostic criteria for depression, or that they're within a range of symptoms that is consistent with normal healthy controls, in 2.6 days. And so that's the average. We've seen people get well, in a day or two. Some people who are particularly treatment resistant, it's the day 4, day 5, but 2.6 days. And so that really,
it's remarkable.
That really kind of, yeah, I mean, that was our goal, to figure out how to get people well as fast as we can through an engineering solution. And with that, we're able to kind of solve the problem out to this, psychiatric emergency issue, where people will come into the psych hospital, or actually come into the emergency room, and sometimes wait a week for a bed, and then they get to the psych unit, and then they have only about a week available for their care before, they kind of start running out of days, or they overstay the block payment for Medicare. And so, that was one of the kind of pragmatic, clinically relevant medico-economic issues that you have to face, is you can't have treatments that extend out all of the treatment time within the hospital, because it doesn't align with the way that hospitalization works now. So what we have to do is we have to find ways to treat people faster, to fit it within the existing infrastructure. And so that was what our goal was, and we succeeded in being able to pull that goal off.
Congratulations on that score. And trying to succeed, particularly with depression. I almost said, take depression, please, like Henny Youngman, take my wife, please. But let's look at depression, because there are psychedelics now that have shown real results. And certainly when we talk about TMS and the same therapy or modality, it's the same kind of thing. The success rates are pretty remarkable and very encouraging. But what about that as opposed to traditional old shock treatment, which is about 100,000 people are still using? I mean, it still has its efficacy, particularly for pretty profound depression, doesn't it?
Yeah, and so, what people call shock therapy or electroconvulsive therapy has been around about 100 years. And it certainly has its place, particularly in psychotic depression, where people are having, issues with kind of reality testing and that sort of thing, alongside feeling, down and depressed. It has an extremely high efficacy. When you get into non-psychotic treatment-resistant depression, which is what a lot of people, the majority of people, suffer from, it's about 48% remission rates, which is quite good compared to, everything else that was on the, available 10 years ago. But, there's been a number of treatments that have come out, and some of which, including SAINT and ketamine, has already been approved, that have a similar or greater effect. And so it's this question of, we need to have more treatments with lower side effect profiles. And so while electroconvulsive therapy is very, very efficacious, for some people it can cause autobiographical memory problems. They seem to resolve when you stop ECT after about 6 months, but if you have to keep doing it, then you can have persistent, memory troubles.
Yeah, memory loss, serious memory
Yeah.
loss. But does it mean that it's better to opt for ketamine, for example,
Well, I think it's,
in most cases?
it's the doctor-patient decision. I mean, I think there's risk benefit in anything. Why we've kind of went after some of the things that we've went after is because the benefit was really high and the risk so far has been quite low. But I think I think that's the doctor-patient decision. I think there's certainly cases where ECT is warranted. I think there are cases where ECT could be warranted, other things could be used, and maybe some of these other things could have less side effects. And that's why I think there's been a real, goal and desire to have other tools, because ECT, in one particular study in a Medicaid population, ECT is only utilized by 1.5% of people that met Medicare, Medicaid criteria to get it. So Medicare and Medicaid were totally happy with funding that 98.5% of people that didn't get it, but they didn't get it, and so that's kind of the issue right now. We don't have a treatment that's been fully implemented and scaled out into psychiatric emergencies that treat these most vulnerable times. And that's what we've been focused on, is how do we come up with ways to do that so that psychiatry really aligns with the rest of medicine. One of us has chest pain right now and kind of, needs assistance, maybe a doctor's, next door, and they could give us an aspirin or check our pulse, but really you have to go to the emergency room because there are more tests and more treatments there. And then you have to go to the ICU or the cath lab because there are even more tests and more treatments. But with psychiatry, there aren't really, there isn't really an escalating amount of treatments. Once you get in the hospital, it's the same or less. And there aren't any tests, and so being able to align psychiatry with the rest of medicine, where you can actually have treatments that are built for emergency settings, always made sense to us.
Yeah, it makes sense in terms of policy, and has made sense more and more as the years have progressed. The two have been aligned to a greater extent than ever would have been imagined, I think. And I was also thinking about, again, shock therapy, and how at one time it was looked upon with such disdain, thanks to writers like Sylvia Plath and Ken Kesey, just to mention a couple.
Yep.
But now it's been very useful. What's exciting to me at this point when it comes to psychedelics, though, and I want to hear from you on this, is Ibogaine, and what the work that's been done with Navy SEALs. I mean, these are people who suffer from PTSD and trauma, and in many respects, the success rate is just extraordinary. Let's talk first about what Ibogaine is. Comes from Central Africa, Gabon, and bark on trees. Has to be extracted and used in some form, really. How is it being dispensed for the most part when it's being used at this point?
Yeah, and so you hit the highlights there. So Ibogaine is one of the alkaloids of the iboga root bark out of Central West Africa, out of Gabon and kind of neighboring countries, and it's been used by the Bwiti for hundreds of years, maybe even more than that. The kind of historical record's a little fuzzy on that. And
Excuse me, it was sacramental, I think, wasn't it?
Sacramental, yep. So it's sacramental. It's something that everybody used. You become Bwiti by taking Ibogaine. That's the criteria to become Bwiti. And so, the Bwiti, use this for hundreds of years. The French discovered it in 1899 and brought it back to France and figured out a way to isolate Ibogaine, and they were actually using it as a medicine in France from 1930 to 1966 when it went on the French controlled substances list in 66, their version of that controlled substances list. And so there's about 36 years of use at really low doses. And then it reemerged as a treatment for opiate use disorder later on. And it's been kind of used in the underground for that purpose. And it's, profoundly helpful anecdotally in kind of interrupting addiction. It sounds like, we don't have, randomized controlled trials to be able to tell you anything definitive, but There's striking reports coming out of these clinics of people just stopping the use of heroin after chronic use or prescription opiates. And so, 6, 7 years ago, there was this idea that maybe you could use ibogaine for other things, and in this case, in veterans with traumatic brain injury and disability and related PTSD and depression. And so, we were connected pretty early on to a group that was involved with sending the first set of Navy SEALs down to Mexico, and really aligned to be able to do a trial at Stanford. We were able to bring folks in before they went down to Mexico to be able to fully evaluate them with neuroimaging, EEG, cognitive testing, clinical testing before, after 1 month, and we're collecting data out to a year. And I was, after talking to some of the veterans, I was pretty convinced that that this was going to be, a helpful intervention for some people. But when I got the data back after we finished the acute follow-up period for the trial, I was shocked. It was very, very successful across a host of symptoms of wounds of war. And it's an interesting situation. There's only, to my knowledge, only one other, kind of prominent historical time where something like this has happened. And it was when James Lind was conducted the first randomized trial of citrus fruit versus other things for scurvy, prompted by observations of sailors, almost 500 years ago. And so this idea that this is a grassroots thing coming effectively again from sailors who observed improvements, in this case from TBI and PTSD and depression after taking this plant-based medicinal substance.
Do we have success rates at this point, or do we?
Yeah. We saw 80+% improvement across, PTSD, depression, anxiety, disability from TBI. There's a lot of caveats to that. This was not a controlled trial. It was an open label trial. It was a smaller number, although there's been a much larger group of people that have gone down there. And so that's been the the caveat so far. But as far as an open label drug signal, it's pretty convincing, that something's there. I haven't seen a drug do this, this level of consistent improvement across patients. And so we've taken that very seriously. We published the first paper in Nature Medicine about a month ago, and we're actively looking into how to get to the next steps with this.
Where's the FDA figure in all this?
Yeah, so the one issue with ibogaine is that it has a cardiac risk profile.
It's supposed to be cardiac toxic, isn't it?
Yeah, so it's not chronic. It doesn't cause a chronic toxicity. What it does is it interacts with a very well-known potassium channel called the Hurg potassium channel, and it can, while the drug's in your system, create an arrhythmia that is only at risk when you are acutely taking it. You're not at any more risk after the drug's left your system, and that arrhythmia is also a risk for drugs that the FDA has approved, right? And so the way the FDA is going to likely look at this is, we're going to let you do it, but under pretty, we're going to let you do a trial, but under pretty strict monitoring requirements. And I think that's right. I think that's exactly what the FDA should say. That this has got to be something that's, heavily monitored within a monitored setting.
Well, I don't want to get too local here, but Scott Wiener, local legislator here in the Bay Area, just put forward or try to put forward a bill that would legalize magic mushrooms, psilocybin, and essentially the FDA said no, but they're allowing for therapeutic use, controlled therapeutic use. That seems to be the trajectory in many respects, doesn't it? In other words, not necessarily to legalize, but to allow scientists like you or others who are psychiatrists and so forth to use these things under controlled circumstances therapeutically.
Yeah, absolutely. So the FDA has been very consistent that within the context of medical trials, they're okay to have this happen. I think state government by state government's been, interesting as far as what this kind of local decriminalization sort of process looks like. And so I think in Oakland and Santa Cruz, maybe even in San Francisco now, psychedelics have been decriminalized. Newsom did not want to sign that bill, to make it, decriminalized for all of California. And I think that, I think the reasoning there is, these are powerful experience amplifying substances that when used in a therapeutic setting in the right way, or in a range, I don't know if there's a right way, but in a range of potential right ways, then you can observe improvements in patients, and
but they're downplaying the recreational use to a great degree now. I mean, not only downplaying it, but really eschewing it.
Yeah, I think this idea that these are, that's different than these are safe compounds that everybody can use, and I think that's probably a place where people can get in trouble, right? And I think that there's been a general hesitation amongst those of us that are in the medical community that are actively doing studies that are very much, kind of have a positive outlook into what this could be, to have pause about trying to do this too fast, right? We don't really do that with other treatments, where you're gonna, start just legalizing a cardiac drug before the trials have been done. We have a process for that, and so I pretty much kind of go down the medical model on this as far as, it needs to go through the appropriate channels. And there may be a moment 20 years from now where we say, okay, this is safe enough that this could be used in a manner similar to alcohol or nicotine. But I think right now, there's a lot of risk in that. And we've seen what nicotine and alcohol have done.
Alcohol is the worst drug. I mean, it's worse than heroin. It's worse than cocaine. I mean, when you stack things up in terms of the negative factors. And by the way, I see a lot of questions coming in, and we will get to your questions shortly. There's lots that I want to talk to Dr. Williams about, but we'll get to as many of your questions shortly as we can. I was just going to ask you, though, Nolan, about we were talking about Ibogaine as a sacramental drug originally. I mean, in terms of having discovered it, and ayahuasca is another example of that, and there are many. I go all the way back to Carlos Castaneda and peyote. Have we really still not discovered what's out there in the Amazon and all these other places? Is there a lot more for us to find out about, in terms of what can be efficacious?
I mean, that's my intuition. It's hard to know what's unknown, but I think that's my intuition. And I'll say that, the ayahuasca story is a very interesting story, right? Because, as I understand it, there's, this is probably an underestimate, 10,000 plus species of plants in the Amazon. And, in order to get what ayahuasca is it's oral DMT plus a monoamine oxidase inhibitor. And so DMT is the psychedelic part. But when you take it orally, it just gets broken down by the liver and never gets to your brain. You need that monoamine oxidase inhibitor, the second piece, to be able to block that process from happening so it can go into your brain and cause a psychedelic experience. And so, these are ideas that we've only understood in the West for, 50, 70 years or something. And it's not
well, forgive me, there was 50 years where the government absolutely prohibited any research at all for any of these substances.
That's right. But this greater idea of what what a monoamine oxidase inhibitor hasn't been known very long. And the idea that somehow the ayahuasqueros knew in some way that both of these plants have to be mixed together and cooked to get this to work is like totally one of the kind of psychedelic anthropological mysteries, right? It's not it's not obvious that you would do something like that without any background in chemistry or in pharmacology. And so, you know, we have very little actual understanding, one, of how something like that happened, to be able to know you have to mix both drugs for it to do anything.
You think it was just
And
random?
I don't know. Nobody really knows, you know. That's the whole thing, is like, you take just DMT orally alone in a cooked mixture, it won't do anything. You won't have an experience. You have to have both mixed together to have the ayahuasca experience. And so, you know, it's one of the great mysteries. And so I think, you know, it's pretty clear that cultures all around the world, or in much of the world, have utilized these sacraments as part of their cultural experience. And so we have that information, and we have this information that in the West, in therapeutic contexts, so far so good. It looks like these things work for a variety of Western defined illnesses. And we have a lot to tackle between those 2 points, right?
Some of these so-called primitive societies have been way ahead of us in terms of what they're able to get rid of, even if it's kind of aligned to an idea of an exorcism or some kind of spiritual process. And we have to catch up with them. I mean, we've been over-medicating for too long from big pharma, and we've been, seems to me, linking psychedelics too much to mental disturbances, when we're discovering now that psychedelics can actually help with so many mental disturbances. I have some questions for you, and we'll go to as many as we can here. Feel free to enter yours. Lisa wants to know, how do psychedelics facilitate changes in mental health conditions from a neuroscience perspective?
Yeah, that's a great question. And so, you know, one of the things that there's a guy by the name of Robin Carhart Harris that's up at UCSF that does a lot of neuroimaging with psychedelics, and so he's found a finding in the brain connectivity that we actually found from that Saint produced a similar effect, where the negative mood region, what we call the subgenual anterior cingulate, is tied together with a self-representation of the brain, or the default mode network, in depressed individuals. And it appears from both stimulation in these kind of mood regulatory regions, as well as psychedelics, you produce a similar brain connectivity change outcome, which is useful, right? That, to me, when you have two very different sorts of modalities producing the same change in the brain, it's more likely that's pointing to a convergence point, right? And so, so that's what, at least, you know, his work and the work that we've done kind of points towards disconnecting that sadness region from the self network, and that seems to be linked to mood improvements. The problem, you know, we're at right now is, not only do we have limited tools on how to modulate these problems, but we have limited tools on how to measure the modulation, you know. And so a lot of the work that's going to come out, I think, over the next couple of decades is going to be really linked to, you know, to figuring out how to better measure what we're changing.
Oh, here's an appropriate question from Bill, following what you just said in a way. He's joining us from New York City. He's joined us from New York City. He says, how do you ensure, thanks for the question, Bill, how do you ensure the safety and ethical considerations of participants in psychedelic research studies?
Yeah, and that's been a tough challenge, right? Because folks are incredibly vulnerable during these periods of time. And there's examples, you know, of scenarios that haven't been ideal within the existing psychedelic literature, and there's a bunch of work to further remedy that, which is, you know, you need to have multiple people in the room. You know, I think people that don't know each other, that are holding each other accountable to being essentially somebody who can hold, you know, a safe space for this person, and make sure that while they're in that mental state, that everything is as they assumed it was going to be going into it. And I think that's where, again, this kind of medical model idea of having folks kind of within a medical context makes a lot of sense. I think because there's a lot of regulations around how all that goes, when you come off of that, I think it gets a little trickier to control. But yeah, I think people, there needs to be multiple people. You need to have kind of an agreement on what's going to happen ahead of time. And then that agreement is what happens. And that's kind of aligned with the way that the FDA sees it and all that good stuff. And I think you can adequately protect people in that vulnerable period. But that's just one aspect of it, right? It's that vulnerable period. And then it's also, any sort of drug related, although rare, as you point out, drug related side effects that can happen after, and being able to monitor people ongoing to make sure that nothing has emerged since then.
Well, I remember confronting Timothy Leary many years ago on the radio and asking him about people jumping out of windows on LSD. I mean, there were actually, cases of that sort, but the doses were probably, in many instances, way too high. And psychedelics, I think the argument can be presented, should be kept from youth in general, shouldn't they? I mean, along with alcohol and other substances, not a good idea.
Yeah, I think, giving, the whole thing with psychedelics seems to be to restore some like earlier state of plasticity in the brain. At least that's how some people are seeing it. And so in a young person that's already got a pretty plastic brain, maybe that's not ideal, right? And so I think as it stands right now, we should be looking into treating people whose brain developmental trajectory is kind of plateaued in many ways, and so we can understand it in those individuals, and then try to think about it once we have a much better understanding of what this is. But as it stands right now, yeah, I agree with you. Kids shouldn't be doing this, and we really got to have a lot of safeguards, against that, and really try to do a lot of work to understand what this does in adults.
Can we talk a little bit about the plasticity of the brain? Because there are many who kind of take it for granted that means we're not, first of all, using nearly what we could use in terms of brain power, or exercising our brain, or just implementing it in some fashion, but applying it. But also, the brain isn't matured and really developed until about age 23, or even maybe a little higher than that, from what I understand. And when I think of plasticity of the brain, I think about a book that James Crick wrote many years ago. It said, all we are neurons. Everything
Mm-hmm.
that controls us and everything that prompts what we do is all neurons. And so what I'm getting at here is that sense of, again, the plasticity of the brain and how we understand it and how we really divine, I'll use that word advisedly, how it operates.
Yeah, the brain is every year kind of decreasing, every minute we're alive decreasing in its plastic nature. And in really young children with epilepsy, it's severe and intractable, 300 seizures a day kind of epilepsy. Rarely the neurosurgeons have to cut part or a whole hemisphere of the brain out to be able to control the epilepsy in that kid, and they're able to reassign function onto the the non-diseased side, and in a lot of these circumstances. And that's because the brain in those really early years can really kind of be very flexible and pliable and change function, all that. And as we get older, we kind of cement in the flexibility of the brain to a level where eventually the flexibility of the brain, in later life is such that it's really hard to reassign function normal conditions. And you see that with strokes in older adults and whatnot. And so there's been just a kind of a general interest outside of psychedelics, but more broadly in this idea of drugs that can upregulate the kind of like more childlike plasticity that you see in earlier life, right? Where you're able to have the brain kind of be able to reassign function, be able to kind of shift function such that it works well. And that's the, one of the ideas of what psychedelics are functionally doing, right? Is that they're upregulating these, what we call neurotrophic factors that are involved in plasticity in the brain, such that you can restore the brain to a more plastic state. And I think that's the big promise. And we think neurostimulation does that too. So again, another kind of parallel there, where we're trying to change and upregulate the system so that the system can kind of be pliable and flexible, nimble to to things that happen to it that may decrease function in a piece of it. And that's something I think that we're going to spend the next couple of decades really trying to sort out. And I think if we can, then we'll be able to solve out not just psychiatric illness, but maybe even neurological illness, which we kind of hinted at with some of this Ibogaine work and some of the traumatic brain injury disability improvements that we observed.
But you're talking
Right,
about things like Parkinson's and supranuclear palsy syndrome and all of those kinds of things, yeah?
Yeah, and there's ongoing studies for instance, for psychedelics and Parkinson's, and so this idea that you may be able to use some of these compounds not just in psychiatric symptomatology, and in that greater promise that we will know more about how to make the brain more pliable and flexible so that it can shift function. And I think that if we can fully understand that, we can fully get down to the brass tacks on how all that works, then our ability to treat the most severely afflicted individuals in society is going to rapidly improve.
One of our regular members, Reed from up in Santa Rosa, wants to thank you for your work, but he also asks, what is the U.S. medical establishment so afraid of with regards to psychedelics when it freely prescribes multitudes of pharmaceuticals from the big name companies?
Yeah, it's all optics at the end of the day. It's all optics. I think that, and in some ways it's enculturation, so I think that if you, as in the period of time before the Controlled Substances Act, before, Timothy Leary was the most dangerous man in America and all that stuff, there was a period of time where psychiatrists were extremely enthusiastic about the potential of psychedelics when they were looking at it with what I would argue to be relatively fresh eyes, and I think that there's been a certain amount of cultural baggage that's been attached to all of this. Some of it as a response to things that probably weren't ideal. Some of it, for other reasons, but nonetheless, it's there, and if these were drugs that we just discovered and there was no Controlled Substances Act and there was no 60s and all that stuff, and these were de novo drugs that humans invented, I would argue that people would be, up on the podium saying that this is, one of the most important advancements in psychiatry. But the problem ultimately is that they do have that baggage, and so you can't make those same arguments.
But even when there was not as much baggage, I'm thinking, of course, of MDMA or ecstasy. For a while it was legal, and therapists were saying it's really useful and getting people less inhibited and closer in touch with their inner life and all that sort of thing. And then, boom, somebody just put the kibosh on it. I mean policymakers in general.
Yeah.
Actually, appropriate question from Tammy in Seattle, Washington. She wants to ask you, looking ahead, and thanks for this, Tammy, what's the next big question or challenge in your research that you aim to address?
Yeah, I think we're trying to figure out, now that we can get these kind of acute responses that are really dramatic and profound for folks, how do you come up with strategies for keeping people well? If you ask a depressed patient, you give, ketamine, IV ketamine works beautifully for an average of 7 to 10 days. And if you give a depressed patient the ketamine and they get well and they get their 7 to 10 days and then they relapse and they're depressed again, it's almost, it's like flowers for Algernon. It's almost harder for them because now they have to deal with the fact that they had this period of time where things were okay and they just can't understand why their brain can't get back to that space, right? And so what we really have to figure out how to do now, once we have all these tools over the next couple of years, assuming that a lot of this goes through the FDA and gets an approval, and the work that we've done that's already been FDA cleared, is this question of how do we keep people well? How do we make a functional cure? I don't want to call it a cure because you're probably going to still need, it's not like an antibiotic where you're not going to get that particular bacteria again, but a functional cure where you can, with ongoing treatment, keep people well in such a way that they don't experience having that illness ever again. And I think that that's what the patients want. So that's kind of what drives us.
Well, if you had to, I don't want to make it sound like betting on the horses or anything, but if you had to put your knowledge to work now in terms of what psychedelics would be most effective and most promising and useful with respect to, because there are a lot of them that are having results now. I mean, if you had to pick one, and can you do this for schizophrenia, for example, or for depression, or for suicide ideation, any of those kind of mental health challenges, would there be a single one that rises to the top, for example?
Yeah, it's a great question. I mean, we're very bullish about this Ibogaine data. It's kind of early, so it's hard to kind of it's a harder bet because it's a newer horse, in that way, But I think that what we're seeing so far is really compelling, and we'll have more data out that it's quite durable. It seems to last a very long time. And so in that way, I think that one is very interesting. But the trade-off is that it's got these cardiac risks, and it's going to require a lot more monitoring to do that. Something like psilocybin, while there are some cardiac concerns, people are worried about chronic use and valvular disease and the heart valves and things like that. For the vast majority of people, this is something that can happen in an outpatient clinic. And so in that way, it's probably more scalable to the masses. And so I think it's very likely that, my view is that the oral daily drugs that we have been utilizing for depression over the course of the last several decades will fade in time to some of these other interventions that work quickly because people just don't want to wait. And that's, it's true at the Burger King line. It's true for medicine, right? And so I think that as a generality, this question of where's the field going, it's really going back. It's going to rapid acting treatments. And I think we're going to have algorithms for risk. We're going to try everybody on one drug that's like or one or two drugs that are kind of the lowest risk. And then if that doesn't work, then we'll escalate up to something that has a little bit more risk, but the potential for profound benefit.
Well, what about the darker sides of this? We like the idea of calling this gray matter because everything isn't black and white, and it's true for some of the ways that we're talking about in terms of diminishing symptoms and getting relief and helping people. I mean, for example, there was a major news story of a pilot who took magic mushrooms because he was depressed, and then he went and opened up a shutter or part of the plane that never should have been open. He could have killed everybody on the plane. And he didn't know what he was doing, or claimed he didn't know what he was doing. Plus, I've been plugging other podcasts that we've done. We did one also with the author, the original Peter Kramer, who wrote the book on Prozac. SSRIs were looked at for a while as being maybe possibly a reason behind a lot of school shootings. I don't know what truth there was to that, or merit there was to that, or mass shootings and so forth. People going nuts on Prozac or on SSRIs. I mean, there's a lot that we don't know in that area, isn't there?
Yeah. So, I mean, I think I'll answer your second question first. I think correlation isn't causality, so it's always hard, right? I mean, it's very likely that people that are depressed are more likely to see the world from a different lens and also be taking antidepressants. And so I think in many circumstances that ends up being, turning violence onto oneself, and being in a situation where folks attempt suicide. And so I think that it's hard to really link anything else there, because I think that there's not a strong causal link. But I think that as a general public health effort, I think that the leading cause of death, I think it's 15 to 30 or something in men, is suicide, right? So it's one of these things where trying to find treatments that are complete, that treat the suicidality first, which SSRIs, at least in some circumstances, don't adequately do, and fast is going to be important. As far as the pilot goes, I'll just link you back to what I said earlier, which is that I'm not a big advocate of like at mass, level decriminalization to the point where, we're not talking to doctors about taking psychedelics. It's really just, anybody and everybody can have access to them. I think that the medical model is in place because we're trying to figure this out and make it a safe thing. And I think that, that pilot, as I understand it, and I don't know the details of the case, but that pilot, as I understand it, they have to acknowledge whether or not they're on, standard mental health treatments, and then that can have a negative financial effect for their ability to fly. And so there's a pressure actually by a lot of these sorts of scenarios to actually do something like that, to take this outside of the medical model and just try to deal with your depression through one of the legal clinics in Oregon. And I think that was, as my understanding, that was kind of what ended up happening there, is he just got access to psilocybin mushrooms and then had what sounds like a pretty protracted bad trip that kind of went on as he went into the plane. I don't think he had any real intention of hurting any of those people. I think he just was misinterpreting reality. And so
He's
that's
being
why
charged with attempted murder, though, because he was responsible for his actions. Certainly, I don't know.
Absolutely.
I don't know if a good lawyer will manage to affect that and get him out of it, but it remains to be seen. What's a concern here, though, is what you just described as a bad trip. There's still bad trips, right?
Yeah, there's still bad trips. There's still, and that's why we need to do more work scientifically to understand that, because there very well could be a series of biological markers that tell us, yeah, this person, if you give them this psychedelic, then their chances of having a bad trip are much higher, or that in this person they need to be more heavily monitored because they're going to have a bad trip. If they elect to do this, then it's going to not be pleasant for them, even if in some circumstances it's still therapeutic after the drug leaves the body. And I think we're just in very early days on that whole host of questions, and so we have to acknowledge it, as you're pointing out, not try to bury it, not try to say this is a panacea without risk. It's certainly not. We need to be able to acknowledge it and say that it is, just like everything else in medicine, there's risk benefits, and then find a good way, a controlled way to understand it to the level where we can really, for most people, curb the risk. And that's, I think, what doctors and scientists are all about.
Talk about curbing risks. Our mutual friend David Spiegel has an app now which helps people do self-hypnosis to stop smoking. You have an app, which I'd like to hear about more briefly in a moment. But what interests me about that is that psilocybin also apparently has some real effects in terms of getting people to stop smoking too. Would you go for the self-hypnosis in the app, or would you go for psilocybin? Or again, how do you make choices there? Huh?
Yeah, it's a great question. I mean, I think as a doctor, we're always trying to find the lowest risk benefit, lowest risk, highest benefit ratio, right? And so hypnosis has an amazingly great low risk, high benefit ratio. I mean, one of the highest probably in medicine. I'd argue that non-invasive neurostimulation similarly has low risk, high benefit. And David and I completed a trial recently where we actually used non-invasive neurostimulation to turn up hypnotizability transiently. And so I'd argue, that's what you have to kind of talk to patients about. People sometimes really want the higher risk thing if they perceive it to be even potentially a higher benefit solution. And so, it's a doctor-patient. A lot of these things end up being really doctor-patient sort of things. I think what we have to do as a generality is make a determination as a medical community. Do psychedelics have therapeutic value? It looks like they do. When we fully determine that vis-a-vis the FDA, then it'll be up to the doctors, to make these calls, and they'll have their own particular decision making, and the patient will too.
So you want to talk about your app?
It's less an app. It's more of an overall kind of treatment platform. And so one of the things that happened after we did a lot of this neurostimulation work is that we were able to actually have some of my students start working in a company called Magnus Medical that that's involved with scaling all these technologies out into the commercial space, and to be able to treat people with this sort of an approach, within psychiatric hospitals. And so I think I said this earlier, but we have the first new technology add-on payment from Medicare. So this will start happening in April of 2024. And the idea is really, it's a whole treatment system, right? It's getting a personalized, getting an fMRI on everybody, getting a personalized brain target derived from that fMRI on everybody, and being able to treat them with this rapid acting stimulation within the context of a hospital stay, with the goal of having something that most people would be willing to do in these high acuity settings. And so, we've got some work to do. I think the company's got my lab's doing a lot of work. The company's doing work to get this to the next step. And we're just trying to make sure that we get this whole thing out there and to patients as quickly as possible.
And you've been working on space learning. What are you doing in that vein?
Yeah, and so that's actually built into that particular stimulation approach. And so what's interesting about the way that we stimulate is that it emulates the memory system. And so I don't know if you ever used note cards to try to memorize anything through school, where you wrote out a bunch of note cards. A lot of people, particularly medical school, used to do that, right? Where you get these 5 by 9 inch cards and you write out.
I used to have a much better memory. I didn't need the note cards back in the day.
Well, that's
good. Not bragging. That's just eidetic memory. Yeah.
Well, that's good. Yeah. I think for most of us, including myself, as my wife will probably tell you, my memory for certain things is not great unless I see it a bunch of times. And I think
I like to say memory doesn't serve me as it used to, because that's the easiest way of describing the process of aging and its effect on memory.
Yeah, that's fair. Yeah. And that's, and memory really for a lot of folks is seeing something and then seeing it again.
Yeah.
Right. And so space learning theory is a theory that's been explored all the way down to basic science level in mouse hippocampus, all the way up to human psychological studies. And so what we know is if you expose the brain to something and then you wait about an hour and then re-expose it, you can re-strengthen that exposure. And if you keep doing that over and over again, then you can build, a memory that doesn't degrade. And so that's what the neurostimulation approach that we've been developing is actually taking the brain's own memory system and playing it back in such a way that you're able to achieve a strengthened memory state.
Here's Reed again, who says, I love that the doctor referenced Flowers for Algernon. Michael Pollan writes of his first-person experiences with various psychedelics. May I ask if the guest has had first-person experience he'd care to share? You're under no obligation here, Nolan.
Yeah. I think as a scientist, we have to kind of separate the personal and the objective, right? And so being able to see these things from a lens of not pure objectivity, because you never can, right? But from a lens of separation, such that we're able to truly apply the rigor. And I think only from that place will mainstream culture be accepting of this. If not, it's a in club, out of club thing,
Promised myself I'd ask you about EMDR and if you have any thing to say on that. I've always been very skeptical about it. This is the notion that, I don't want to be too reductive sounding here or flip about it, but a lot of eye blinking can help with trauma.
Yeah, people have looked at it. I mean, I think that the problem at a fundamental level with a lot of this stuff is that because we don't know what the problem is in the brain itself, and we can't measure the problem in the brain, that it's very hard to know if something quote unquote works, right? We have readouts of it from scales that the FDA is good with using for approving drugs and approving devices. But at the end of the day, to really answer that question, you have to know what the mechanism of that intervention is, and you have to know what the pathogenesis of the illness is. And so, there's been a not clean record for EMDR, and there are a lot of questions about it, at an individual patient level. If somebody seemed, if it was helpful to them, then that's great. I think there
are people who swear by it.
Yeah. Yeah, and why that's happening, is TBD. I think that that's why I've kind of I'm in some ways I'm pretty picky and kind of a purist about it. I'm trying to look for doing things that are really interrogating the brain itself, so that I don't that it's less guessing and more perturbing and understanding.
Well, talk about purists. I'd like to hear you speak, if you would, about that uh, experiment that was done with Mormons, because they knew the Mormons hadn't used any drugs, so they found there was no damage as a result, right?
Yeah, and so it was. I think it wasn't. It didn't require you to be a member of the church, but you had to have a history of only MDMA use, and the high probability of only MDMA use is highest, it appears, in Utah, and so that probably is aligned with certain views for the majority of the proportion of people in Utah. And so I think that was the kind of goal there, and with that, a really interesting study design, right, where they were able to see kind of pure MDMA cognition and see that there wasn't an apparent cognitive hit there. And there's been subsequent follow-up work, with people going through these trials, participants going through these trials where you don't see it. And it was really to combat some of the early monkey work where, folks were saying that, that MDMA was causing quote unquote holes in the brain and all that. That actually ended up being a mistake in that lab, and they retracted the paper, and they actually gave those primates methamphetamine.
Well, there's still so much to learn about the brain, and also about psychedelics and the effect on mental health, and for that matter, a lot of physical health as well. Where should research be going, in your judgment? Where is the next step? And if you were to triage it, what would be deserving of the most resources at this point?
Yeah, it's a great question. I mean, I kind of look at it, similar to blood pressure, right? We've been changing our blood pressure goals of what's an ideal blood pressure for a long time, and dropping those numbers over and over as we get better at dealing with the worst of the worst. And I think that that's probably the direction that this will go to. There's probably a bigger problem that we're not even looking at right now, with kind of stress and health and the culture that affects all of us. And then some people's brains are more susceptible to having more symptoms, and then we call that major mental illness. And so we're going to have to conquer the major mental illness issue. And I think, and however long that takes and what that means and, what that is, and I'm optimistic we can eventually do it. But then when we get to that point, then it's going to be, well, how do we optimally live, right? And how do we optimize brain health? And I think that's the next, frontier, but it's one that's pretty far away. We're still in this major mental illness space, but hopefully in my lifetime, my kids' lifetimes, they'll be able to see a world where we have a lot more control over these problems, and we have a lot more, a lot bigger tool basket for treating these problems.
On that hopeful note, I want to thank you, and give thanks also to all of you who joined us for this episode of the Gray Matter with Michael Krasny podcast. And thanks ahead of time to all who will be hearing us on Apple, Spotify, or at graymatter.show, where we urge you to go, if you haven't already done so, to become a member of this podcast. And once again, that's at graymatter.show, and it's gray with an E. And please let me know if you have any thoughts or suggestions. You can reach out to me at mkrasny@graymatter.show. And my thanks to our terrific Gray Matter with Michael Krasny team of Alex, Shannon, Chad, Cullen, Jeff, and Colleen. And a special thank you to this week's guest, Dr. Nolan Williams of Stanford University.
Thank you.
I'm Michael Krasny.
Bandwidth for Gray Matter is provided by CashFly at CACHEFLY.com.